I would like to request our next speaker,
Sorry? Questions?
Dr. Abhishek Yadav.
We can take questions at the end of this session.
So, good morning, everyone. And at the outset, thanks to Dr. Ramdeep for this invitation. And as always, I think he's done this job perfectly too. So, are we already started? So, I'm going to be talking about right lobe implantation. And I'm sure that all of us in this hall have our own ways of doing it. But I'm just not to teach anything, but just to show that how we do this technique. So this is to start with a little bit about the benching. So that's the segment 8 vein, and we generally use ring PTFE graft for reconstruction. Though recently we've switched over to Dacron, and we found that it handles much better, and we're probably more comfortable with Dacron now. This is a punch that 2 mm punch that we used to make a hole in the graft. And the difficult vein, the segment 8 vein, is always reconstructed first. The corner sutures. Once we started to switch to Dacron, we found that this part has become much easier because it's more pliable and it's much easier to handle than PTFE. That's the anterior layer being completed. Check for leak, and then the segment 5 vein. Check for leak again, and then we join them to the right hepatic vein, the common ostium, and you can see that it turns out very well. You can in fact see all the small openings inside the vein when we join it to the right hepatic vein. So I think after we switch to this technique of a unification, we've been very happy with the results. Then sometimes when you have multiple 8 veins, or you have 8 veins in a different alignment, then sometimes you have to resort to using these Y grafts so that the alignment of the graft does not change. Then coming to the recipient, always a side clamping. And then the opening into the right hepatic vein is about 1.5 times the size of the donor graft vein. I think it's very important to clear all this adventitia away from the place of the anastomosis. It really helps and aids in a better anastomosis. So this is important that since we've incorporated the middle hepatic vein into the right hepatic vein of the donor, so obviously the donor anterior layer is going to be much bigger than the posterior layer. So therefore the corner stitches are not in fact corner stitches on the recipient, they're in fact posterior stitches, because the anterior layer is going to be longer in the donor. So instead of taking corner stitches, the stitches are placed slightly posterior on the recipient side, and the liver goes in. However, on the donor side, the corner stitches are perfectly corner stitches. There you can appreciate that the recipient side, it's not exactly on the corner, it's slightly posterior, because the anterior layer on the donor side is going to be bigger than the posterior layer. Corner, and then continuous posterior sutures. Of course, the assistant's role is of paramount importance in this step. It's always better to have a consistent assistant every time that you're doing this implantation. That really makes a makes a world of a difference when you're doing these, especially in different difficult implantations. There's the posterior layer. Now this is what I was trying to stress, that that you can see that the anterior layer here is of the donor side is much bigger. So therefore, once we take the corner stitch, the posterior stitches on slightly away from the corner, we can have a much bigger opening there on the recipient side, hence incorporating the extra length that we have on the donor because of the graft there. And then incorporate the PTFE graft into the same opening, reach the midline, the graft. Then we're going to start from the opposite side, from the lower end. And then once you reach the midline, then depending on how much length you've got left there, extra length, you make a venotomy on the anterior layer to incorporate the extra length which is available from the donor side because of the graft that is sitting there. Finish off these anastomos, the tying, but we don't tie this suture till the end. We tie it only after reperfusion so that the graft can swell up and then you can incorporate that extra length. That's the portal vein. Nothing special in the portal vein. We always take marking sutures which makes the identification much easier, so you don't waste time during the implantation figuring out where the septum is on the donor side, etc. The normal corner sutures. I think the only thing we do differently in a portal anastomosis is that we take the anterior layer interrupted, and this is a lesson that we picked up from our pediatric cases. And after we switch to taking interrupted anterior layer sutures, we found that our flows are much better, and our radiologists are also much better. They say that the flows are they see that the flows are much better, and of course our complication rates have also come down quite significantly after we switch to the anterior interrupted technique of portal vein. The corner stitches are tied together, obviously, because you're doing an anterior interrupted layer, so you don't need a growth factor. You can just tie the sutures together. And that's the anterior interrupted layer. I think there's a few advantages that obviously you don't have to worry about the growth factor when you're taking interrupted stitches. Also, when you're doing a thrombectomy, etc., sometimes on the donor side, the portal vein will be thinned out. So when you're taking interrupted sutures, I think it helps because interrupted sutures you can place at different distances, especially on the donor side. So if you have a thinned out portal vein, I think it's a really beneficial technique. And then after that is completed, now it's time for reperfusion. So like I said, we don't tie the hepatic vein, we tie it after the reperfusion. Slow release of the clamp. It's always important to keep talking to your anesthetist and slowly release the clamp. We generally do a graded portal release. And then the hepatic artery. Hepatic artery, we have 2 or 3 techniques depending on the circumstances. We use different techniques. In this video, I'm just showing the normal flip over technique that I think most of us are used to doing. And obviously, clearing the adventitia is, I think we all know this. I'll not go into the details. But what I want to stress is that it's always better to have more than one technique for arterial anastomosis in your armamentarium, because sometimes you can get into problems. Sometimes the length of the artery might be short. You might not be able to flip over the artery. So in those situations, we use that the posterior suture first technique. But however, this is the traditional technique that we all have been taught and we all are used to. Taking the anterior stitches first, and then we are going to flip over the artery. That's the flipping part. I think what we started doing a little differently is that instead of trying and repositioning the bulldogs and trying to twist the bulldogs, that becomes a struggle. So what we just do is that we apply a different bulldog from the opposite side. So I think that also makes it a little easier. Then there's the anterior layer. being completed. Standard technique, and that's the artery after reperfusion. Very good, especially after that the unification technique. We've started getting really good triphasic flows always, and of course when you have such good outflows, then most of the times you can be quite sure that your graft will do well. Bile duct anastomosis, nothing fancy about the bile duct anastomosis. The only thing I wanted to show was this apparatus that we use, which is something known as the blower mister. So this is basically an equipment which the cardiac surgeons use during the bypass surgery. It blows out CO2 and water. It blows out a mist. So when we all know that when you're doing the bile duct anastomosis, it's so messy. There's blood coming around. The bile duct is flopping on it. So this is a very nice thing, which what it does is blows carbon dioxide and blows a mist of water. So it clears all the blood coming in the way. And what it also does is that it keeps the bile duct open, because it's a flow of carbon dioxide coming. So it keeps the bile duct open. So it really facilitates the suture taking. And you can see this. So the assistant does not have to poke his suction back into the view all the time. And I think this is a really beneficial technique. I think we've sent this for publication and it should be published very soon also. So that, other than that, nothing fancy about the bile duct anastomosis, simple techniques. Thank you very much for your attention.
Do you routinely use a Dacron or sometimes the vein graft from the donor as a jump graft?
No, if you're talking about the explant portal vein, no, we've stopped using that. Yeah, we always use PTFE or Dacron grafts.
And why a ringed PTFE? Why not a simple PFT? I think so. The new MHV might be, the patency rates might be improved with the ringed PTFE graft.
I don't think the patency rate of the graft depends on the material that you use. I think it matters on a lot of other factors. But yeah, I mean, we also moved away from using ring grafts. Like I said, that this was a video which was taken a few months back. Now we started using Dacron. That is non-ring Dacron.
So you never use the recipient portal vein for reconstructing the new MHV?
No.
And you always do that single anastomosis of the outflow?
Yes, all the time. Yes.
So have you ever seen any complication with relation to the PTFE graft in the new MHV in the longer, I mean, not in the short term, the post-op long term?
Not really. I mean, I cannot pinpoint to in one of the patients we had like refractory sepsis. We were not sure where this patient was getting sepsis from, so we thought that it's from the infected graft. We went in and removed the graft also, but the patient did not improve. So I mean, I don't have any conclusive thing to say that we have had any graft-related complication. But out of the 300 odd cases that we use this graft, we've not had any perforations or any of the other complications.
But there has been instances of
there have been reported
fistulations.
Yes,
and causing
I know they have been reported
bleeding and
they have been
deaths from it.
Yes, but we've not seen any of those in our series at least.
Hello. I'm sorry for interruption, but we can take one question. Yes.
One question for the donor surgeon, Dr. Shyamsukar, could you tell us any particular, anatomical problem where you would not do a minimally invasive approach for the donor?
If multiple inferior veins in the donor, if the donor liver graft size is more than 900, or the multiple hepatic duct, then we usually don't take that kind of donor. We usually prefer single duct, one inferior is okay, and donor graft weight should be less than 800, 850.
Another question for you. how do you deal with an unexpected bleeding from the IVC?
It's usually
Which
not
can
happened.
happen, which happens from time to time.
No, it's usually not happened. We do very cautiously. So till time, if it's happened, then we have to convert it open. Then there is no
So
option.
you have a backup of open things.
Yeah.
That's the thing. Okay. Thank you.
For that PTFE-CAVA anastomosis?
6 so
Because
we just use the normal proline only.
is it easy to take?
I mean, we were told I mean, you know, all these company people, they told us use Vascofill, etc., etc. But we've tried both Vascofill versus the normal proline. It does not make a difference. I think it's all marketing gimmicks.
Okay, and regarding that erosion PTFE, we had one patient. After 4 years, he vomited out the graft, but nothing else happened. One patient had erosion.
Thank you so much, and especially that I think the Mister is a very useful thing, and maybe you can share it more, the videos or whatever, because I think it's brilliant.
No, it
And
does make the biliary anastomosis a breeze.
yeah, and I think just a comment that, as Abhishek said, as our practice is, Bora does the same. Abhideep said he does the same. I think we've moved completely to PTFE instead of using the portal vein grafts, and it's like many centers now are doing it with very gratifying results and saves a lot of time, I think. So this was an important message
I
as
think
well.
especially in lesser volume centers like less manpower centers, because for extracting the graft you need a big team. You know, someone has to be sitting on the back table. So for people who are like lesser members in a team, like smaller.
Yeah, but
programs-
as you're becoming busy and busier, I'm sure you won't change the practice.
No, obviously I will not. Yes. Thank you.
Thanks to
Thank
our
you very much, everybody.
Yeah, thanks to our
Thank you,
chairpersons for
Professor.
sharing the session and our speakers. Moving forward to our next session, can we have a quick group picture with all the chairpersons and the speakers? I request Dr. Shyam Sundar and Dr. Abhishek Yadav to please join in for a picture.